Hi, everyone. Welcome. We'll give everyone a few minutes to get signed on.
Okay, I think we can get started here. So, hello everyone. Welcome to our DBS educational seminar. We hope that today's session will be a useful reference for information regarding living with DBS devices. So I'd like to start by introducing Dr. Lan Lo, the co-director of the Beth Israel DBS program. Dr. Lo finished her medical degree in neurology residency at Baylor College of Medicine. She then trained in a movement disorders fellowship at Columbia University Medical Center in New York. Dr. Lo is currently a movement disorder specialist and co-director of the DBS program here at Beth Israel. And I'll hand it over to her now to begin today's seminar.
Great. Thank you so much, Michael, for that introduction. So I want to welcome everyone to the first DBS educational webinar. And I have invited the representatives from all three DBS manufacturers to join us in today's webinar. And just briefly mention who's with us today. So from Abbott, we have Mr. Greg Lambert. And from Boston Scientific, we have Mr. Matt Hillary. And then from Medtronic, we have Mr. Thomas Gilligan. So you guys can say a few words about yourselves now. Why don't we start with Greg?
Hey everybody, my name is Greg. Thanks for having us here. I think we're all going to talk a little bit about the devices in general, so I'm excited about it.
Great, thanks. Matt?
Thank you so very much, Dr. Lo, and thank you everybody for joining the call today. My name is Matthew Hillary. I'm a clinical specialist with Boston Scientific DBS. I've been working with DBS patients and their physicians for about 8 years now. And again, thrilled to be here today. Thank you for the opportunity to chat a little bit about your therapy.
And Thomas?
Good afternoon, everyone. My name is Thomas Gilligan, just like Gilligan's Island. I'm with Medtronic DBS, and I live in Boston, Massachusetts. And I've been with the company for 7 years now and been covering DBS for two and a half years now. Looking forward to today's event.
Okay, great. Thank you. So basically, the goal of today's session is to have your questions, your most frequently asked questions answered regarding kind of daily activities for an individual who's had deep brain stimulation. And we go over some of the questions I've found that I've been asked about most commonly in the clinic setting. and then I'll ask each of the representatives to take time to answer them. And then for the second half of the webinar, I'll actually open it up to see if any of the attendees will have any specific questions that we can help answer. So this is really about your time, and then trying to see if we can help answer any questions for those who've recently been implanted with a deep brain stimulation device. So without that, I'll just go on to some of the questions that we have already set out. So the first, I just want to mention there's no conflicts of interest pertaining to this talk. I don't have any pertinent disclosures regarding this webinar today. So the first 6 questions, I'll just go alphabetically. First, I'll direct these questions to Greg. Some of the questions I hear from some patients of mine is that if people can resume their normal day-to-day activities after the DBS is implanted, and about when would that be possible? And then also particularly if swimming is a safe to do with DBS.
Thanks, Dr. Lowe. Everyone, welcome once again. So the short answer is yes, right? This is the reason that people very often get DBS, is that they can go back to doing things that they feel like should be a part of their lives. And that's a great reason to do DBS. So the short answer is yes. The longer answer is there's usually a period of restriction following the surgery, and the best person to follow that is your surgeon. So talk to your doctor and follow their post-surgical recommendation. So it depends on the physician, but it's usually going to be several weeks to a couple months, and that's usually just to let healing go on. Is swimming safe? So this is a notable exception. So if you Google DBS and swimming, you're going to come up with a couple articles. Again, the short answer for this is yes, but. So in 2020, there was a FDA safety communication. It didn't have anything to do with a particular warning or a particular device. It just said that some patients, after undergoing subthalamic nucleus DBS, and they were good swimmers, kind of haven't been able to swim as well. And the total number was 9 or 10. It's not very widespread, and it wasn't in every instance, but it happened enough where it was a communication that was put out. So when people ask me about this, I say, hey, it's not something that's been studied extensively, but it happened enough times where people were good swimmers that they couldn't swim anymore. And the best guidance that you can see, and it's pretty much, if you go to talk to your doctor, they'll say the same thing, or any of the online pamphlets, is generally, if you're a person with Parkinson's with DBS, you probably should be swimming alone anyway, because your symptoms could change. So if you're gonna swim, make sure you're with somebody, and be very careful if you start, and kind of watch how this interacts.
Yeah, that's great. Yeah, I also want to emphasize that, after DBS, you should be in the shallow side of the pool, and then always have supervision. And then right now, we're not sure if what's happening is directly related to DBS. So it may be also maybe related to like Parkinson's disease, that there could be a lack of coordination between the limbs, which would make swimming difficult. So there's still more research that need to be done to really evaluate that question, if that's a direct, relationship there. And then the next question is, what about with scuba diving or skydiving? Are those activities that can be done like on vacation with someone with DBS?
Sure, with the first exception, right? Scuba diving, unless you found some new great way to do it, is underwater. So the swimming warning kind of applies. But with scuba diving, there's something unique about the pressure of the system. So the devices against all 3 companies generally have a warning against a pressure of water greater than 100 feet. So if you're going to scuba dive and you're going to swim and you're under supervision, there's a depth limit, and that has to do with the pressure the device can withstand. Skydiving, and it kind of goes along with any high altitude sports. So skiing, mountain climbing, there's nothing that's been studied about the altitude that's going to bother your DBS system, right? The implanted system. But skydiving, is kind of one of those activities that puts a lot of stress on where your general device usually sits, right? So if I had a deep brain stimulator over my collarbone and you're going to skydive and you're going to put on a harness, one of the things that you're going to find in talking to your surgeon, your neurologist, is things that impact the area of the device or are jarring like that are generally something you want to avoid. So while there's not a hard fast do not skydive with DBS, because altitude, there's a very good reason to be super cautious when you're putting on anything like a harness that's going to run over where that DBS battery and wires sit. I mean, if you've done the system, you've gone through a lot of work to have this great improvement in your life, and you'd hate for something to happen that could just be avoided otherwise.
Okay, great. And what about using like industrial equipment or power tools? Let's say, for example, if a tree falls and lands in your driveway and you're trying to maybe saw off the tree into pieces. Is that something that is feasible with DBS to use the power tools?
So most household appliances and power tools are fine, with the big warning that, like, the same thing, right? Anything that, like with the skydiving, the harness is touching where the device is. So any power tool that makes contact with your shoulder or is resting against the device is something you want to avoid. So think of the device as the implantable pulse generator all the way through the extension. So anything that's going to rest in this area, right, or impact the device physically is something you want to avoid. But power tools you can use, with the exception, and this kind of goes into the next question, there are some things that have very, very large power generation requirements, like an arc welder, or if you work on high tension wires, they can create a magnetic field, and those are things you want to avoid.
No, how about with household appliances like microwave or fridge? Is that going to be interfering with DBS?
No. So the next question, right, that goes into the same thing. There's this, in the 3 different companies that make this, if you look up their safety warnings, there's something that you're going to see in the back of this: electromagnetic interference. And that's just a fancy way of saying things in the environment that use electricity. Your household appliances are in that category. So your microwaves, your fridges, all the things are generally going to be fine. The things that can cause interference, and what that interference usually means is it turns off and on your system, are things that create a really strong magnetic field. So the devices themselves, right, and this is inherent in the way they work, have a magnet mode. So sometimes they can be turned on and off with a magnet. Your physician can turn that off, but if the magnet is very, very strong, it can interfere with your device. So a good way of looking at this is, if you're going to interact with something new, don't have it be on top of a ladder or something that's unfamiliar. But for the most part, the household appliances are fine.
Okay. And how about with someone who's thinking about using like a hot tub or saunas or tanning beds?
So those are also generally things that should be fine, with the exception of extreme temperatures. So a tanning bed, a hot tub, a sauna, all of those things, once your surgeon says, hey, you're healed and you're not gonna, the incision is fine and nothing's gonna happen, generally those are all done at temperatures that are not gonna cause damage to you as a human and are gonna cause damage to your system. That being said, extreme temperatures should be avoided.
Okay, great. How about with increasing or decreasing the strength of stimulation? You know, oftentimes that certain individuals may be given that the parameters to adjust the settings themselves. Do you have any suggestions for someone who's thinking about doing that? And of course, you know, reaching out to the movement disorder specialist is one of the first things to make sure that that person is on board with whichever adjustment they're doing. But any other guidance about that?
No, exactly what you said, Doc. That all systems, right? The physician can choose to give their person with the device a range or potentially several programs, and they may even ask you to try them between the two of them. And that can be, for some people, they have no problem, and other people, they kind of, oh no, I would prefer that you do it. Both instances are good, but if your physician does give you the opportunity to switch between programs or to change like the strength on the program, if they told you it's fine and they want you to do it, you can go ahead and do that. Just make sure you're cautious and have somebody around, or you're sitting. And then if you're a person that's very, if you find, right, you're very sensitive to changes, just go really slow. And you're never wrong to call into the office and say, hey, can I get a little guidance for this? So just go slow.
Okay, then that's it for your set of questions. Then the next slide. I'll direct these questions to Matt of Boston Scientific. So first question is DBS therapy a permanent procedure or a surgery?
Great. And thank you again, Dr. Lowe, for the chance to address your patient. So compared to things like ablative procedures or maybe focused ultrasound that create permanent lesions in the brain, which are irreversible, your DBS system could indeed be removed if better therapy were developed, or say a cure for Parkinson's disease. Now, DBS leads are engineered to last a lifetime. Some IPGs are engineered to last 3 to 5 or even 7 years. And the most recent rechargeable IPGs are expected to have 90% of their battery life at 15 years, which suggests they're going to last a very long time indeed.
How about with people undergoing medical tests or procedures? For example, if my cardiologist said I need to have an EKG done, or my PCP said I need an X-ray, a chest X-ray, or other CT scans, is that something that's compatible with the DBS system?
Absolutely. So the gold standard now for all DBS systems is that they be MRI conditional under certain conditions, and each manufacturer can provide your physician and your MRI radiology team with the necessary protocols to ensure safe scans with your device. That includes MRIs, it includes CTs and X-rays. It's interesting that you mentioned EEG. I had a nice conversation with a physician not too long ago that was questioning whether or not his EEG test would interfere with the DBS, and I said, actually, conversely, my DBS therapy is likely to interfere with your EEG, and it's as simple as just turning the system off, undergoing some scans. Very easy to do with your patient remote. It's often just a simple button. Turn it off during the scan, turn it right back on afterwards.
Yep. Yeah, and if anybody has any further questions, we're always available to reach out to us if you have any, or if you're not sure about how to turn the device off and then back on after the procedure is finished. How about going through airport scanner with the implanted DBS? This is, I think, also one of the some of the questions that we have gone into in the Q&A, but does that pose any interference with the DBS, or is there anything special I have to do for the scanner?
Great. Yeah, another good question. So most of your TSA agents are very familiar with protocols surrounding implanted devices like DBS and pacemakers. So by mentioning to the security personnel that you have an implanted device, they'll likely avoid you to, instruct you to avoid the large scanner and instead give you a simple wand treatment. Like Greg was mentioning earlier, most of the things you're cautioned against with your DBS system are powerful magnets and large electromagnetic interference. And it's possible that scanners at the airport could provide sufficient amount of interference to temporarily turn your system off, which is why I always recommend that when you do travel, you bring your little remote. Right? It's very easy to travel with, and it's also very simple to check after you pass through security that your stimulation is on. But again, the TSA agents are very familiar with this. You get a permanent implant card that says, hi, my name is, and I have a DBS device, though I've never seen any example of anybody being required to show the card, though it's a nice thing to keep with you, right? When you get that in the mail, tuck it in your wallet or your purse. There's a couple of helpful phone numbers on that kind of card that can help contact people if they ever have any questions, but no problems whatsoever passing through TSA security.
Okay. How about some of the symptoms that could be responsive to DBS, or other symptoms that may not be as responsive? If you can kind of go over what those could be?
Absolutely. So with DBS, we're looking to mitigate the motor symptoms of these movement disorders, things like tremor, rigidity, bradykinesia, right? Slow movement, and dyskinesias, those jerky movements, are all responsive to DBS. Symptoms that are not typically responsive include the non-motor symptoms. Some patients suffer from insomnia or depression and fatigue. And though those things aren't necessarily responsive to DBS, what I find is that once you manage the motor symptoms and kind of parse those out, it's easier for your physicians to come up with strategies to address some of those non-motor symptoms.
Right. Okay. Yes, and specifically about some of the motor symptoms, something like walking difficulties or balance, those are may not be as responsive to DBS, and that's actually an area that I'm of my research that I'm looking into to see what how we can affect certain parts of the brain to help with those particular areas, like walking difficulties or freezing of gait, for example. So that's something else to keep in mind. But those two questions will actually go into more depth during the DBS Ambassador event that's coming up at the end of October. So that will be also helpful to for anybody who have further questions about that. How about symptoms which could be DBS induced, for example, during the programming session, and sometimes an individual may experience maybe some tingling. If you can kind of go through an overview of what those could be.
Yeah, absolutely. So symptoms such as dysarthria, right, difficulty with speech, paresthesia, as Dr. Lowe mentioned, a little bit of tingling sensation, and dyskinesias are all common side effects of stimulation. For this reason, it is important that we have the ability to steer current away from areas in the brain likely to induce these symptoms while continuing to stimulate areas that are helping to reduce the motor symptoms. Now, it is common in the initial programming and also in the OR during awake procedures to work to try to induce some of these symptoms, which help us better map the anatomy so that we have a really good understanding of where we are and help confirm that we're right in the exact spot that we want to be. This, again, is helpful to allow us to steer away from those side effects while maintaining good therapy.
Right, and the directional, with the directional lead technology, that's one of the advantages is that of the systems is that to help to direct the stimulation away from a particular area which may be causing the stimulation side effects, and then towards areas where the stimulation will be better tolerated.
Absolutely.
Okay, great, thank you, Matt, for that.
My pleasure.
And then this next 6 questions will be directed to Thomas of Medtronic. So the first question is about if DBS effectiveness can decline over time, and what are my options if this would happen?
All right, so some of the disease states that DBS helps with, such as Parkinson's disease, can progress over time. And as a result, some of your symptoms that were previously treated when you were initially implanted and programmed, like tremor, may reappear after a few years. That being said, minor adjustments to your stimulation settings, like increasing the amplitude or some adjustments to medication in conjunction or on their own to the stimulation adjustments, can help combat the onset of some of the progressive disease states and symptoms that you may experience over your continuum of care with your DBS system.
Yes, yeah, so especially some of the studies which looked at this question, I think the long-term studies do show effectiveness of DBS over time, but then the neurodegenerative diseases like Parkinson's may progress over time. So that's where the DBS therapy may need to be adjusted, like Thomas mentioned. How about DBS stimulator? Is that compatible with someone who has a pacemaker? And then the second part of that question is, does having a DBS make you ineligible to have a pacemaker, which is one of the questions in the Q&A that someone wrote?
Yeah, so if you already have a pacemaker installed, we can install the DBS system on the opposite side. So it's rather simple. In fact, I was with a patient a few months ago who had a DBS system as well as a pacemaker. We did have both reps on hand just to make sure there was no interference between the two devices. And after, the procedure was done, we just did, some simple checks to make sure that both systems were running correctly. So again, if you already have a pacemaker implanted, you can get the DBS system on the other side, and there should be no issues.
And then the same would apply for the opposite question. If someone has DBS, then they are still eligible to get a pacemaker placed.
That is correct. In the rare circumstances, let's say you already have a DBS system over, on your left side, over the, in the area of your heart, you could place that system in the abdomen. It's very rare that would happen, but there are options to do that.
Okay. How about when the battery, or the IPG runs out? What would happen to the symptoms?
Yeah, so if your battery runs out and it turns off, you will lose your stimulation for the time being. And when that happens, your symptoms, such as tremor or dystonia, whatever you originally had gotten DBS to help with, will most likely arise rather quickly. So again, if you had tremor and you were able to suppress the tremor with your DBS system, and your battery shuts off, you will see that tremor come back rather quickly. And at that point, we would know we would need to replace your battery, which kind of leads us into the next question here.
Right, and then that's one of the other things I want to add is that when the battery is becoming depleted, you should reach out to the neurosurgeon's office to set up an appointment for the replacement of the battery. That would be the most important. And then the next step would be also to get in touch with your movement disorder specialist to see if maybe adding medications could help your symptom in the meantime. So for example, if the Parkinson's symptoms may reemerge when the battery is depleted. So which means that maybe your dopaminergic medications need to be tweaked a little bit. The same goes for essential tremor. That you may have a worsening of tremor while the battery is being depleted and is in the process of needing a replacement. So and then the same goes also for cases of dystonia, where if you have a posturing or certain abnormal positions of your body, which DBS can help with, if the battery is depleted, in that case, the dystonia symptoms or the posturing may get worse. And then battery replacement is the key to those scenarios. And then how about someone that needs a tremor control for both hands to perform a certain job? Would it be possible to have DBS on both sides of the brain?
Yes, absolutely. And that's very common. So quickly, the left brain works the right side of the body, and the right brain, or right hemisphere, works the left side of the body. So if you had tremor in both hands, we would implant both hemispheres. And conversely, if you just had a tremor on one side, we would implant the opposite side of the brain. So you can absolutely implant a DBS system to effectively control tremor in both hands.
How about during nighttime or before bed? If someone has a DBS, would they be able to turn it off? For example, if someone has a consideration about conserving battery life, is this something that could be a useful strategy?
It can be, and it's something that we see with patients who have essential tremor, which is an action tremor, meaning when they're at rest, there is no tremor, but when they are moving, some of those dexterity issues will start to pop out. And so as a result, if you're going to bed and your tremor is controlled because you're at rest and sleeping, you can shut the battery off at night to preserve your battery longevity. So that's a discussion that I would have with your neurologist to clear with them beforehand. But it absolutely is an option, especially for those essential tremor patients. In my experience, for patients with dystonia and Parkinson's disease, I usually see the battery, the DBS system remaining on 100% of the time.
Okay, great. Thank you, Thomas.
Yeah, absolutely.
So this next part are just two general questions that I'll have each of you answer. The first question is about MRI scans with DBS system. And then the second question is what are the latest technologies that you foresee for DBS, or especially covering the subjects of directional leads or rechargeable batteries or a closed loop system. So I first have Greg answer these couple of questions, and then we'll go through to the others.
That's good, thanks. So the first question, right, can I have an MRI scan with the DBS system? The short answer is yes. The way it's going to go, though, is let's say, you know, God forbid you fall and need a knee surgery. You're going to go into the doctor and they're going to say, hey, ma'am, I'd really like to get an MRI. And you're going to say, oh, I have a deep brain stimulator. And their eyes are going to get really big. And because it's something they see all the time. So what you do is you say, hey, this is the number from my neurologist's office, and this is the card or the type of device I have. Contact them and they'll help you arrange an MRI with a particular scan, because the answer is yes, but there's some systems and it's different for every device that the MRI needs to be in, that the radiologist needs to use. So just make sure that if someone says you need an MRI, you follow up with either somebody from the company or your neurologist, and they'll help you do that. The second thing, right, latest technologies. So at Abbott, what we're particularly proud of is in the last year, something called Neurosphere. So every Abbott patient ever implanted, so going back to day one from Abbott, and every Abbott patient in the future has the ability now with a software update, right? There's no change to device, there's no new system, there's no surgery, to have their neurologist remotely access their settings from their office and change systems in their programming. So everything that you've done, from a battery check to the questions like, hey doc, is my battery, how much is left? Or I want to make a little adjustment on my DBS. Everything you've done in person, you can still do that, but now you can do that from anywhere there's an internet connection. So you can do it from your home Wi-Fi, you could do it via your cell phone, and your neurologist has the same capability. So that little tablet you've seen them use in their clinic, they can do that. And while this is happening, you're FaceTiming with them from your remote control. So you're looking at them, they're looking at you, you're talking, having a conversation. So it's very similar to the telehealth visits that everyone, I'm sure, in the last year has gone through. It's kind of become routine in this COVID era. But now, in the background of that telehealth visit, your physician can see, assess, and update and make changes if they want for your DBS system. So we feel like particularly proud of that. The second thing is, with that software update, you can now use your phone to control your DBS system as a remote. So you could go to the Apple App Store, download an app, and that app from your regular, like my cell phone, can interact with your device. So in instances where you need to travel, or you're a person who frequently changes program settings, you no longer have to carry two devices. Thanks.
Great. How about I'll go to Matt for these two questions.
Wonderful. Thank you so very much. So again, I like the short version on, can I have an MRI? The answer is most certainly yes, right? Every IPG that Boston Scientific provides is most certainly MR conditional, full body MR conditional. And I agree with Greg, you should always have the contact info for your doc and your industry representative. I love to get these calls. I love to talk a technician through exactly the protocols they need to scan our patients safely. So keep those numbers for your representatives in your back pocket and have the confidence that you can indeed continue to get those MRI scans when necessary. For the latest technologies, I want to touch on two things, please. So we've seen a flurry of innovation in DBS technology these last few years. At Boston Scientific, we've recently delivered our fourth generation of generators in just 3 years. And this cadence of innovation shows no sign of slowing down. As we continue to drive advancement in this industry, we maintain our focus on patient comfort by providing the smallest, longest lasting rechargeable IPGs, which help to ensure fewer repeat surgeries. We also want to provide you and your physicians with the most precise and consistent stimulation control to ensure that as your disease progresses, we can maintain the best possible therapy. Right? There are literally millions of permutations and configurations for therapy possible with the newest directional leads. And for this reason, we provide your physicians with easy to use tools for delivering this therapy. We were the first in the world to provide this directional DBS and have over 6 years experience designing the support systems like the clinician programmer and the charging systems and the patient remotes to help provide you with the optimal therapy and your maximum comfort. And that rechargeability is no small thing, right? It's come up a few times during this call, right? There's no concern for overnight battery drain if you have a rechargeable device. There's no loss of therapy while waiting to schedule something with your surgeon, schedule a replacement battery procedure with your surgeon. And I saw a question come through from Alan, great question about, what if I forget to charge my device and it totally depletes? No harm, no foul. Like Thomas mentioned, when that battery totally depletes, your stimulation will be turned off. But the second you re-put a charge on that rechargeable device, it'll kick right back on at those pre-programmed settings. And there's no damage whatsoever done to the device by fully depleting it. So again, quick recap, rechargeability, right? Smallest possible device that's going to last the longest, and directional steering to optimize that therapy delivery and minimize your time in the clinic.
Okay, great. And then finally, we're a little bit short on time, but if Thomas, you can also address the latest technologies for DBS. I think the MR scan question has been already addressed, and it's the same response for all three.
Yes,
of you.
that is correct. You can have an MRI. With the latest DBS technology upgrades for Medtronic, we do have directional leads with the steering capability. We do have a rechargeable battery, but within the last year, we have done a complete overhaul of our entire system. Most importantly, with our battery and its brain sense capability. So that's what we're calling it. But I want you to just think of it as the ability to see brain signals from the implanted system that you currently have. So the only new item you would need is our newest Percept PC battery. For those that have been implanted many years ago or getting implanted or recently implanted. With the addition of our Percept PC battery, we now have the ability to look at your individualized brain signals, which we know directly correlate to many symptoms such as tremor, dystonia, dyskinesias. And why this is important is because, as we talked about, some of these symptoms can be progressive and they can change over time. So we can use this information to help give you the proper stimulation and medication throughout your continuum of care with your DBS system. And I just want you to think of it like an ECG, being able to read the heart to understand if it's beating too fast or too slow and how to treat it. We now have that ability, which is unique to Medtronic, in being able to see your specific brain signals that we know have signatures, specific signatures for tremor, dystonia, so on and so forth, and giving you, using that information and giving you potentially, the best optimal care. And with that, we're currently looking to finalize our clinical trial to do closed loop, where we would essentially read these brain signals. And for those of you, as we discussed, if you have essential tremor and you don't need your stimulation at night, this closed loop therapy would automatically lower your stimulation without having to manually shut it off. Or conversely, if you were wearing out from your medication dose and tremor was starting to become more prominent, then the device would automatically increase your stimulation. I do want to preface that this adaptive closed loop therapy is not out yet, but all the technology is housed within the system and will be available as soon as we get FDA approval.
Okay, great. Thanks so much, Thomas. So now we'll go on to any questions in the Q&A and the chat, which have not been answered yet. So Hannah or Anya will help to call out those questions.
Yeah, so I'm just going to go in order here from the Q&A questions that we've received from the audience. So the first one, and any of the panelists are welcome to answer these, is what happens to a DBS apparatus when someone passes away?
Yeah, so do any of you want to help answer that? Can just
I can step in here quickly. I recently experienced this where someone I was in communication with had reached out and let me know the passing of their spouse. We can take, Medtronic can take this device back and run tests through it to see what had happened. With that being said, it is not on a need to happen basis. So if you're aware of it and it's something you think of, we'll absolutely take it back and run it through tests, but it is not something that we need back.
Great. Someone has asked, I have Medtronic's replaceable devices, not rechargeable. When it is time to replace my batteries, can I get an upgrade if something newer has come out in the meantime?
Yes, you can. So that's something that you will discuss with your neurologist and your surgeon. You feel free to reach out to me as well. And at that point, you will be eligible for a rechargeable battery or our newest Percept PC battery. And this will all be discussions that you will have with your neurologist and your neurosurgeon. But most importantly, as I mentioned before, the leads you currently have implanted are eligible to be placed into any of the batteries that we have.
I'd like to piggyback on Thomas's answer if I could. I most certainly agree, right? When that battery is due to be replaced, it's the perfect time to upgrade your system. I know that in addition to the options provided by Medtronic, Boston Scientific has also worked hard to make sure that we have options for you for upgradable technology as well. So I agree with Thomas, check with your physician, do your homework. You most certainly have options.
And then we have another question about the smallest size of a rechargeable battery available from Boston Scientific. Would that be a chest-mounted IPG or a skull-mounted one, like the one in the clinical study in the UK called EchoStime?
So that was a question about the Boston Scientific Rechargeable and where it's implanted in the body. Yeah, right. So ours is the smallest IPG implanted under the clavicle. I am aware of neurostimulators on the market for maybe things like epilepsy or neuropace, currently approved medical devices that are implanted in the skull. But that's not a current option offered by Boston Scientific. So again, we're thrilled to be able to offer the smallest in cubic centimeters, the smallest in thinness device that should be the most comfortable possible in that subclavicular region.
Someone has asked regarding dexterity, how much dexterity is needed to use the remote? Is it a concern if someone is clumsy? Any trouble with that?
Greg, I'd love to give you a chance if you want. You know, I'm chomping at the bit to continue.
We
Sure,
can let,
I can talk about that.
Great.
I mean, I think the answer is going to be the same for everyone, right? Like generally, if you're considering a DBS system for movement disorders, you're probably not typing at 200 words per minute. So it's nothing to be ashamed of, and it's something that everybody happens to. So I think all of the devices are usable and accommodating for someone. The biggest question I get sometimes is, hey, I don't think I want to deal with that. And I think Dr. Lowe can answer this too, right? I would say 50% of the people who get DBS systems don't use their device very frequently, their remote control very frequently, right? They let the neurologist set it up, they go on, they live their lives, and the device, the remote just stays in the drawer somewhere. So don't let that stop you for sure.
A great point.
And next, could we have each rep discuss the time between charges for their rechargeable batteries?
Absolutely. So I find that in my practical experience, our patients are charging somewhere between 30 to 60 minutes a week. Though not because they have to, because that makes them most comfortable, right? So the Boston Scientific rechargeable battery will last about 6 weeks on normal settings. So consider bilateral STN implants running at about 2.5, 3 milliamps, kind of normal settings, 6 weeks without a charge. But I always suggest to patients that you think about it like the gas tank in your car, right? If you fill up every time you run down to the corner store, it fills up very quickly. It doesn't take very long, right? If you drive all the way to Connecticut and fill up an empty tank, it takes a little bit longer. So those patients that are recommended to charge maybe 30 minutes a week might instead choose to charge an hour every 2 weeks or 2 hours every 4 weeks. I most encourage folks to find a routine that works best for them. So you have a lot of flexibility and a lot of options there.
I agree with everything Matt said as far as the Medtronic system goes. We usually suggest 30 to 60 minutes as well, once a week. One thing we will do in addition is we'll take your exact stimulation settings. So you're at 2 volts, 60 pulse width, 135 hertz. We'll take your impedances, which is just another metric we use, and we'll be able to give you a good idea as to how long your battery will last given your exact stimulation. And then once we give you that information, it's, I think, up to you to decide how it fits best into your daily schedule, daily, weekly, monthly schedule.
So I'll chime in there. Abbott does not make a rechargeable battery, with the idea being, right, our primary cell battery is lasting on average 6 years. So and that's from our oldest implanting center in Europe when we first approved. By and large, rechargeable batteries are not the most common for patients with movement disorders. And then on top of that, generally what we see, and I think this is true for most implanting centers, that there's a subset of patient population who do require a rechargeable battery. And that's very often people with high expected settings. Very often it's people with dystonia, or people who are very young and they're expected to, they're going to go on living with DBS system for 30 years after their implant. But aside from those population pools, Abbott's very much in the camp that you should get a device that you just set and forget, not something that you have to manage, even if it is once a week or twice a week or once a month. We're much more in the camp that this is something you should get and it should take care of you. You should not have to take care of it.
So following up on that train of thought, for rechargeable versus non-rechargeable device, there's a question in the Q&A for any advice for patients living alone in terms of selecting the rechargeable versus non-rechargeable device, which I ask Matt to answer.
Yeah, thank you. So it is always a wonderful thing, right? When there's a live-in caregiver or loved one who is able to help you manage your disease state. I find that it's a conversation best had with your physicians, right? Before you're determined a DBS candidate, you go through an extensive workup, right? Lots of different tests, physical, psychological, et cetera. And some folks I find actually, and forgive me for disagreeing with Greg a little bit, I find that most of our patients are opting for rechargeable. And yeah, they do so for the size of the device and because how charging has been made so easy and such a low lift for patients. I feel like it goes really well, but I would most certainly never talk somebody into having to manage a device if that were not in their comfort zone, which is of course why Boston Scientific offers the full range of both rechargeable and primary cell options. I will say that over the last, maybe I'm going to say 2 years in the Boston market, I bet you we've implanted the 90% of the batteries we've implanted have been rechargeable, and we hear great success from our patients in doing so.
Yeah, and then one comment I had to add on to that was I think it's more a matter of choice. If you're somebody that is able to, for example, recharge your cell phone, well, then you should be able to do the recharging of the DBS battery. So it kind of, you can use that as kind of a guidance. And then the timing of the charge can be up to you in terms of setting a time every week to do the recharging. So
thank you for that. That is perfect, right? I will most certainly use that. If you can charge your cell phone, you can charge your IPG.
Yeah, and then with the iPhone, you just kind of you throw it on the dock on a daily basis versus the DBS device you do like weekly, so it's actually less frequent than the phone. What about in terms of someone, just a follow up on that type of question, if someone's traveling outside the country, like for example, like Europe, and it's a 220 volt, then would you use like adapter to when you have to charge while traveling?
Thomas, you want this one, sir?
Yeah, so you would need to get, first off, let me start by saying, always bring your recharger system with you when you travel overseas or for any extended period of time, right? Although we know, it's going to last you 3 weeks, a month, whatever it may be, you never know what may come at you. So it's always a best practice to bring your recharger system with you when traveling for an extended period of time. As far as the 220 volts, I believe you mentioned, you'll just need to make sure you get a adapter plug to go from US to Europe in order to recharge your charging station or your recharging remote.
Yeah, totally agree with Thomas. And yeah, my wife carries around one of these little kits that will adjust to all the different types of European power available. They sell them in airports. If you happen to forget, you're on your way through and you stop at the little tech shop, you can absolutely buy one of those adapters. And totally agree with Thomas. If we're traveling, let's bring our remote, let's bring the DBS charger, but you'll find it as easy to charge over there as it is over here.
Yeah, I actually have one of those. It's the gadget you can switch if you're depending on which country you're in or which continent. So it works really well. Yeah.
Yep.
So how about, so I can answer the next question in terms of if a DBS parameters are set comfortably, how often would you have to return to your neurologist or movement disorder specialist? So that's a great question. And I would say between 6 to 12 months once you're on a stable setting. And if you're not having any issues, no emerging symptoms, then that can be checked between 6 to 12 months. Yeah. So, but that often depends on, you know, the practice of your neurologist or movement disorder specialist. But I would say definitely at least getting a yearly checkup is advised. Just so, for example, if you do not have a rechargeable battery, then that's something the movement disorder specialist can take a look at your battery life to see how much you have left in terms of the IPG or the battery. And the other question, would the battery run down with extra physical activity? Greg, do you want to answer this one?
Sure, yeah, the short answer is no. So batteries, whether they're primary cell, right, ones you don't have to charge, or rechargeable, ones you do charge, what drains the battery is the energy of your settings. So think of that as like what your neurologist programs your device to do, and then how long you have it on. And then the third part of that is like how hard your body is pushing back against those. And everybody's different, but those are the three things that are gonna drive that equation for battery being used. It's independent of what you choose to do with your life once you get the activities you want to do back from DBS.
Okay, and the next question is about for the battery for the closed loop system, would that potentially consume more power, and would that reduce the battery life or increase the frequency of recharging?
Yeah, it's a great question. So it isn't approved yet, which I do want to make clear. And with that being said, we haven't been able to estimate what type of draw it will have on the battery exactly. So we're still working on that. With all of that being said, our newest Percept battery that has this BrainSense technology, the technology to do the closed loop, the adaptive therapy that you're asking about, we increased that battery longevity by 20% compared to our previous PC battery. So we are geared up to have a more efficient system, knowing that we may be pulling more energy from it. But that technology is still under the works, and we will have more data available on how much battery draw it will have once it's approved. Again, right now we're in the clinical trials, and this is all information that we're looking to figure out and report back.
Oh, and then actually one of the follow-up question to that is just if you can clarify what the closed loop system is.
So again, let's think of it as throughout the day, your patients have fluctuations, okay? They take their meds, and then their meds slowly start to wear off, and then they may get a bit more rigid, or their tremor may come out. Or if they take their med dose and they're at their peak dose, they may get some dyskinesias, and those uncontrollable movements. And where this closed loop therapy comes to play is that we're able to sense the brain signals that we know correlate to tremor, to dyskinesia, to dystonia. And when we see these signals rise, we will look to suppress them with stimulation automatically. So think of it, we'll set thresholds. We'll set an upper and a lower threshold that we know work well specifically for you and your symptoms. And then as this signal starts to increase, we will suppress it automatically with more stimulation to subside that tremor. Or if the brain signal is very low and we are starting to see dyskinesias start to come out, we will lower that stimulation automatically. So it's technology that's doing the work for you. Whereas right now, all the DBS systems are setting you to a stimulation and leaving it there through the continuum, or at least the foreseeable future, 100% of the time, unless, of course, you shut your therapy off at night. So it's adaptive. Just think of it as working for you and your symptoms, excuse me.
Okay, and then the final two questions, I guess this is more about clarification, whether a converter or would be needed to convert the voltage from 120 to 220. Matt, if you have any guidance there.
Thank you for the question. So I'm not sure I completely understand. We're trying to make a distinction between the amount of voltage coming out of the wall socket compared to what your device will successfully manage. Is that correct?
Yeah, I think this pertains to the traveling, for example, or converting from 120 to 220.
Yep. So you'll forgive me, I don't have a great deal of experience here. I wonder if any of our other panelists might have more experience with a converter compared to an adapter.
So I don't know specifically, I'm in the same boat, but I will say I've had patients with rechargeable batteries travel overseas, and the adapter that Matt and Dr. Lowe were talking about, converting from US to Europe or wherever it may be that you're going, I haven't got any complaints, and I believe it charges the system. It may just charge at a slower rate. But with that being said, these recharger systems have battery in them themselves that should give you a full charge at least. So it will maintain, it should charge. I've heard of no experience for my patients traveling overseas where this is an issue.
Yeah, I absolutely agree. And so say your washing machine or your dryer at home runs on a whole different breaker, right? It takes two of those things, 220, a different plug. You're never going to work to try to plug your charger or your remote into one of those types of outlets. But all the outlets you come across in hotel rooms and restaurants and airports when traveling should be very easy to use the adapters.
And then because we're short on time now, actually going over, but the last question, if we can address that one, is how large are the remotes? By that, I'm assuming that they mean the patient programmer. If each of you can demonstrate, or if you have that in front of you, that would be great as well. Great.
Here's ours, very small, tactile buttons, easy to see screen, easy to navigate, sleek.
Okay. How about Greg? I don't know if you can show any patient programmer.
I can, yeah. So every patient that gets an Abbott system goes home with an Apple iPod. It's a fully functioning Apple iPod. We just put an app on it. But like I said, in the last year, your cell phone is now your remote. So go to the App Store, download the app, and your phone without you don't have to put something over your chest or use a bridge device. Your phone itself talks to your device. So it's whatever your cell phone is if you choose to use that, or an Apple iPod.
And Thomas?
And with the Medtronic system, I don't have one in front of me, but you will get an Android phone similar to your newest iPhone or smartphone out there that we issued you. It does have a communicator that goes with it and gives us the ability to have our own telemetry line, Bluetooth line to your device and your device only. And that's something that we do all through a Bluetooth connection. So again, just think of it like a cell phone or your newest smartphone.
Okay, awesome. Yeah, so with that, I wanted to wrap up this first DBS educational webinar. I want to acknowledge Anya Russell, Hannah Babcock, and Michael Wynn for helping to organize this event, as well as the representatives from Abbott, Boston Scientific, and Medtronic for being here and answering all the questions. If anybody would like a copy of the PowerPoint or the responses to those questions, you can reach out to Anya Russell and she can send that to you. And then be on the lookout for the upcoming DBS ambassador session, which is the end of October, I believe October the 28th at 2 p.m. So for anybody that's thinking about DBS as a treatment for Parkinson's disease or essential tremor or dystonia, that's where we'll address the questions concerning that topic for looking at the candidacy of DBS. All right, thank you so much, everyone.
Thank you, Dr. Lowe. Thank you, everybody.
Thank you, everyone.